Okay, so now this will keep you awake, hopefully, as we go through some questions. We'll just get started here. Let's see. There we go. Okay, so first question. 3 years ago, a 15-year-old boy was treated for Ewing sarcoma. For the past month, he has complained of worsening fatigue, exercise intolerance, loss of appetite, persistent dry cough, and lower extremity edema. The total dose of adriamycin he received was 575 milligrams per meter squared, and he also had received irradiation to the thorax. So, your most likely diagnosis is, you can choose on the right. No music. Okay, so cardiomyopathy was the most common answer, and that is correct. So whenever you see a patient on the boards who's had adriamycin or one of the chemotherapy drugs that can cause cardiac toxicity, and they present with symptoms potentially consistent with cardiomyopathy, this is a cardiomyopathy until proven otherwise. Okay? Other things could cause these symptoms like anemia and pericarditis, but when they give you the clue of chemo treatment, choose cardiomyopathy. Okay? All right, second question. The most important factor in planning follow-up for a child with Kawasaki disease is, and choose your answer. Dr. Sabella just covered this nicely. So yep, you got it right. So the answer is D, presence or absence of coronary artery anomalies. So that's really the factor that determines going forward the risk for this child long term for cardiac problems from Kawasaki's. So good, you guys look like you got that one right. Okay, question 3. Following an uncomplicated delivery, a 3.7 term baby developed cyanosis immediately after birth. At 3 hours of age, the child was cyanotic. The heart rate was 140, which is normal. Pulse oximetry was low. It was 70% in the right hand and 85% in the foot. When you put the baby on 100% FiO2, the sats did increase by 5%, but not higher than 90%. So this is cyanosis consistent with congenital heart disease. The patient had a normal chest X-ray. So given these findings, what is your answer in terms of the most likely diagnosis? So I will tell you here, the key here is reverse differential cyanosis. Lower sat in the right arm than the foot. And that gives you your correct. D is the most common answer, and that's the correct answer, transposition of the great arteries. So on the boards, most cyanosis that's differential is going to be higher in the hand than the foot, and that's usually pulmonary hypertension, PPHN. If it's reverse differential cyanosis, the diagnosis is most likely going to be transposition of the great arteries, and certainly for the board exam, it'll always be that. Okay, question 4. A 3-week-old infant presents with tachypnea, tachycardia, hepatomegaly, and poor feeding. The least likely diagnosis is, and here's the list, VSD, tetralogy of flow, coarc of the aorta, aortic stenosis, and dilated cardiomyopathy. So this is least likely diagnosis. I will tell you they're trying to get away from these on the boards as far as using things like least likely. But you're correct. This would not likely be a VSD. And the reason is that doesn't usually present with heart failure until you're older, until your pulmonary vascular resistance drops. Typically, VSDs present around 2 months of age. Tetralogy of flow, you're blue, you're cyanotic, co-arc of the aorta, aortic stenosis could present this way, and dilated cardiomyopathy can present this way as well. Tetralogy of flow can also present this way, but if it's a pink tent, which is less common, so the answer would be VSD. Okay. Actually, I think, yeah, that would be right. The other thing that would be unlikely would be tetralogy of flow. Okay. So a 3-month-old girl is being evaluated for her first episode of wheezing. She feeds slowly, sweats during feeds. So when you hear sweating during feeds, think heart failure. Her weight is low at 5th percentile compared to her length, so failure to thrive. And she has an ejection murmur at the upper sternal border and the left posterior thorax. Her lever edge is down below the right costal margin, and she's diffuse wheezing. What's your most appropriate initial step? So really what this is trying to clue you into is this child is presenting in heart failure with signs of congestive heart failure and failure to thrive. And so, if you're thinking heart, the first appropriate step here would be echocardiography, C, and that's what most of you said. That's correct. Chest x-ray could be another initial step, but not to rule out a foreign body. Okay, question 6. A term infant is cyanotic and requires intubation, so we'll assume that they have respiratory distress. Baby has a heart rate of 175, a little fast. Blood pressure is kind of borderline, 60/30. Increased right ventricular activity on exam, a single S2, short systolic murmur, equal arm and leg pulses. Chest x-ray shows a normal heart size, but the lungs are congested. On your ABG, on 100% FiO2, your pH is normal, your PO2 is low at 43. And your CO2 is essentially in the within range of normal. So the most likely diagnosis is yep, most of you said number 5, E, and that's correct. So if a baby is blue from the start, has a normal heart size, and the lungs are congested, and you know, that look like more congestive heart failure, not hyaline membrane disease, and the cyanosis does not correct with oxygen, TA PVR is your most common diagnosis. The other diagnoses, tetralogy of flow usually doesn't present with respiratory distress, and your lungs aren't congested when you're blue. Hypoplastic left heart usually does not present, first of all, this early in life, and also you tend to have weak pulses, and not pulmonary congestion right from birth. The key here is this happened right from the delivery room. So that's total anomalous pulmonary veins. Okay, so number 7, a routine 1-month evaluation. You hear a harsh 3 out of 6 murmur, high-pitched, whole-low systolic, mid-left sternal border. Your most likely diagnosis is? Correct. So of most common congenital anomaly in heart is a bicuspid aortic valve, but they don't usually present till they're older. The next 2 most common lesions are ASD and VSD. So this is describing a small VSD that the patient's asymptomatic from, and you just hear a murmur. The other diagnoses, ASD, you don't hear a murmur at this age. Aortic stenosis, pulmonary stenosis, don't give you a holosystolic murmur. They give you a systolic ejection murmur. And tetralogy of Fallot usually presents with cyanosis for the purposes of boards. Okay, question 8. A 5-day-old infant brought to the ER with a 2-day history of poor feeding and lethargy. Pregnancy, labor, and delivery were uncomplicated. He went home at 48 hours of age. And on physical exam, his heart rate's now 190, so tachycardic. Respiratory rate's 80, so he's breathing fast, and his blood pressure is 50/30, so low. He is pale and mottled with cool extremities and weak pulses. The most likely diagnosis is VSD, ASD, hypoplastic left heart syndrome, tetralogy of Fallot, and double aortic arch. Okay, so correct. So they're trying to give you a clue of a ductal-dependent left-sided obstructive lesion. So hypoplastic left heart would be classic. This could also be a presentation of someone with coarctation of the aorta or aortic stenosis. We said before, VSDs don't usually present at this age, ASDs either. Tetralogy of Fallot, the key for that is your blue. And double aortic arch presents when you're older, usually with airway issues, not with heart issues. Okay, question 9. A 19-year-old college student with a history of a small VSD presents to the ER with a 4-hour history of sharp right-sided chest pain. The pain's worse when he breathes in. He reports that over the past month, he's had night sweats and lost 10 pounds. So the most appropriate initial response is, do you want to get a TEE, give him antibiotics, ceftriaxone, get an echo, do a TB test, or get blood cultures? And most people got the right answer on this one, blood cultures. So again, Dr. Sabella did a really nice job going over endocarditis. So this would be classic presentation, and as he said, it can happen in hearts that are otherwise normal, but most commonly happens in the setting of congenital heart disease, either significant or hemodynamically insignificant, like this boy had a small VSD never treated, but yet he remains at risk for endocarditis. And of course, we get blood cultures for endocarditis. Okay, question 10. 2 weeks after surgical repair of an ASD, a 2-year-old boy presents with anorexia and irritability. So he's not eating, he's cranky. On exam, he's pale and his extremities are cool. The heart rate is 160, so a little on the fast side. His radial pulse is difficult to palpate during inspiration. So of the following intervention, what's the most likely to be beneficial is oral ibuprofen, 10 mg per kg, Q6, thoracentesis, pericardiocentesis, IV saline bolus, or cardioversion. And the correct answer is going to be C. Yep, you're right, pericardiocentesis. So this is a classic presentation of post-pericardiotomy syndrome. Again, Dr. Sabella did a nice job talking about that. They're saying the pulse is difficult to palpate during inspiration, that's pulsus paradoxus. So this is like think pulsus paradoxus if you hear something like that. They also might say, as Dr. Sabella said, he feels better leaning forward. They can usually breathe better leaning forward. All clues to big pericardial effusion. And the treatment is drain the fluid. Okay, question 11. Regarding the proposed use of pulse ox screening for critical congenital heart disease, the AAP recommends, and the answer, you can choose the answer. Is it A, screening should be performed within 12 hours of age? B, screening should be performed by the family? C, oxygen saturation should be obtained in both hands and 1 foot? Pulse ox reading with less than 5% absolute difference between the upper and lower extremities considered a pass, or in the event of a positive screen, CCHD needs to be ruled out with an echo. And the answer, yep, that's the correct answer for this question. You also can take this in light of potential sepsis or other systemic illnesses that could cause a patient to be peripheral desaturation, but in the sense that the baby otherwise doesn't look like they're septic or have systemic disease, then you would do an echo. Screening should be performed after 24 hours of age. It should be performed by the healthcare facility and doctors or nurses. You get saturations in one hand and one foot. It's usually the right hand and the foot. And pulse ox reading can have a narrow absolute difference between upper and lower extremities, but if it's less than 90%, it's still abnormal. So that's kind of a trick 1D. Okay, question 12. A loud systolic murmur is heard in a term newborn at 2 hours of age. Your most likely diagnosis is A, transposition of the great arteries, B, TAPVR, C, tricuspid regurgitation, D, large VSD, and E, PDA. So yeah, this one was a little more difficult. So if you are at 2 hours of age, you're just transitioning out of, from birth, the most likely cause of the murmur that's loud is going to be, and systolic would be a TR. So PDAs usually don't close this soon, so you hear that when they're a little bit older, and it's usually a continuous murmur. So this would be an Epstein's anomaly, for example. When they have congenital severe TR, you can hear it early in life, so 2 hours. So TAPVR, no murmur. Transposition, usually no murmur. And large VSD, as you said before, no murmur. So that's the answer here. Key is PDA is continuous murmur, and you usually hear it when they're a little bit older than this. Okay, next question. A bicuspid aortic valve is commonly associated with all of the following except, and the answer can be either truncus arteriosus, transposition of the great arteries, Turner syndrome, aortic aneurysm, or coarctation of the aorta. So this is an except question. All except. We got a smattering here. This is obviously not easy. So the answer is going to be transposition of the great arteries. So truncus arteriosus is very common. You commonly have an abnormal aortic valve. It can either be bicuspid, tricuspid, quadricuspid. You can have 5, 6 cusps. But it's common to have aortic valve anomalies, including bicuspid valve with truncus arteriosus. Turner syndrome is very commonly associated with bicuspid valve and coarctation of the aorta. Aortic aneurysms come with aortopathies, which are associated with bicuspid aortic valve. And coarctation of the aorta is commonly associated with bicuspid aortic valve. So the answer is transposition. Usually your aortic valve's normal with transposition. So this one will be a tough one. I guess this is just this is something you're going to have to learn about congenital heart disease. But transposition, only 4% of the patients have bicuspid valve. Okay, which of the following findings could be normal in a newborn? Your choices are A, a wildly split fixed second heart sound, a precordial thrill, a systolic ejection murmur, lower oxygen saturation in the right arm than in the right leg, or a systolic ejection click. Okay, and the answer is, actually most of you got this correct. Systolic ejection murmur can be normal during transition from birth. All the other ones thrills are generally not normal. Even a venous hum shouldn't make a thrill. So ejection click is never normal. Differential cyanosis, especially lower in the right arm than leg, is never normal. And a wildly split fixed second heart sounds kind of a clue for either an atrial septal defect or a bundle branch block. So consider that abnormal as well. So, but you all know in pediatrics we often hear sort of a soft flow murmur, right, which is an ejection murmur. So they can be louder at birth during transition time. So a systolic ejection murmur is not always abnormal in children or newborns. And you have to do additional fact-finding to figure out if it's a problem. Okay, next question. The physical finding most suggestive of hypertrophic cardiomyopathy in an adolescent athlete is, your choices are A, bilateral ptosis, B, a single second heart sound, C, diminished pulse in the right arm, D, continuous murmur heard in the left back, or E, a systolic murmur accentuated by standing. So this is like the guy that Pete described who died on the basketball court. So if the doctor had done a correct exam, what would he have found? The answer is you are correct, E. So when you have hypertrophic cardiomyopathy, you have variable left ventricular outflow tract obstruction, which is accentuated by hypovolemia. And so when you're squatting, you have high SVR in your legs, right? So think about it. Your legs are bent, high pressure to get blood into there. So it's basically increasing your systemic vascular resistance. When you stand up, all of a sudden the heart's pumping against lower resistance and can empty easily. So when the heart volume goes down during systole, the murmur gets accentuated by the low volume in the left ventricle. All the other ones are just red herrings here. Okay, number 16. Regarding infective endocarditis, what is the correct answer? So is it A, clinical diagnosis is made utilizing the Duke criteria? B, echo is the definitive diagnostic modality? C, ASD is a predisposing heart condition? D, most cases are culture negative, or E, systolic ejection murmur indicates valvular regurgitation. Again, Dr. Sabella did a really nice job. I heard him present the answer here. So your answers, most of you said A, which is correct. So this is a clinical diagnosis using a set of criteria, Duke criteria in this case. Included in the diagnosis are usually positive blood cultures. Most cases are culture positive. ASDs don't predispose to this, and echo is not the gold standard for making the diagnosis. Okay. The other thing Dr. Sabella pointed out is, if you do have a murmur, it's not always a systolic ejection murmur. Valvular regurgitation, this is kind of a trick, is usually a systolic regurgitant murmur, or holosystolic murmur. Okay, question 17. Which of the following signs is most likely to be present in children with endocarditis that's infective? Is it A, Osler's nodes, B, fever, C, systolic murmur, D, splenomegaly, and E, splinter hemorrhages? So all of these can be present, but by far the most common is going to be fever. So you guys got that one right. Excellent. So 90% of patients will have fever. The other findings are less common. Okay, number 18. An 18-month-old boy has had persistently high fever for 7 days. You suspect Kawasaki disease. Of the following, the physical exam finding that's least likely to be present include, so this is another least likely. Again, we're trying to get away from these on the boards, but for now, it's at least likely to be cervical lymphadenopathy, edema of hands and feet, polymorphous rash, purulent conjunctivitis, or strawberry tongue. And let's see if you read this carefully. So this is a trick question in that the answer is D. You don't get purulent conjunctivitis with Kawasaki disease. It's usually non-purulent, just red eyes that are erythematous, but no discharge. So this is kind of a trick question. You got to read the answers carefully on the boards. Okay, number 19. Which of the following statements regarding coronary artery aneurysms due to Kawasaki syndrome is true? Is it A, that most patients die from aneurysmal rupture if they have sudden death? Coronary artery aneurysms typically appear 3 months after Kawasaki syndrome. The risk of the giant of coronary artery aneurysm is decreased by IVIG. Echo evaluation at 3 months intervals are recommended for all patients. Or E, there is no correlation between the duration of fever and the development of giant coronary aneurysms. All right, so most of you guessed or answered C, which is actually correct. So IVIG and high-dose aspirin decrease the risk of development of coronary artery aneurysms. So good. All the other are wrong. Usually sudden death, if you're going to have, is usually from an MI, and that's usually by a clot associated with the aneurysm, turbulent blood flow in the coronary. Coronary aneurysms usually appear right early on in the disease. That's why we do the echoes at diagnosis 1 to 2 weeks, and then 6 to 8 weeks. Okay. Echoes only go on for in the future beyond 6 to 8 weeks if there are aneurysms present. And the sooner the fever goes away, the less risk for developing aneurysms. Okay. Number 20. Another Kawasaki syndrome or Kawasaki disease question. So if you have a patient you suspect Kawasaki, when's the best time to administer IVIG? Is it A, after the congestive heart failure subsides? B, after the fever subsides? C, after you treat with steroids? D, as soon as the diagnosis is made? Or E, when cutaneous manifestations start to resolve? And the answer, yeah, you guys, woohoo, we got 100%. All right, Camille, be happy. Okay, number 21. Which of the following organisms is least likely to cause infective endocarditis? Least likely. Again, this is another least. If they have any more of these on the boards, they will be capitalized and probably bolded. So just to clue you in, this is least likely. So there's A through E, different organisms. And I know you heard this too, or most of it. So it looks like we're a little bit mixed here. So most of you guessed 3H flu, which is correct. So the most common organism is Staph aureus. Second, I believe, is the strep viridans group. Staph epi and Enterococcus are in the mix for the next couple most common. And it's rare to have gram-negative and especially encapsulated like H flu. So most of you got it right. Looks like some of you were fooled by Enterococcus, but that is actually, I think it's about 10% of endocarditis is Enterococcus. Okay, question 22 is a long lead-in. A previously healthy 8-year-old boy cannot walk because of right ankle pain. His left knee was sore and swollen 3 days ago. Findings include elevated temperature, blood pressure is okay, heart rate's okay, maybe a little fast. He has a 3 out of 6 holosystolic murmur at the apex rating to the axilla. So that's holosystolic murmur, swelling, warmth, and tenderness of the right ankle. Of the following laboratory test, what's most likely to be associated with these findings? So what does he have? And then they're asking you, what's the next step? So do you want to do a blood culture? And will that grow strep viridans? Well, you most likely have an ASO titer that's elevated, ANA titer that's elevated, rheumatoid factor elevated, or a urinalysis showing microscopic hematuria. So the key here is migratory polyarthritis, large joints, and also another clue here would be the holosystolic murmur, which is a regurgitant murmur. So this sounds like MR on exam. So you're correct. The answer is elevated ASO titers. This is rheumatic fever. Okay, Next question. A 1-day-old term infant has dysmorphic features that include a low nasal bridge, flat occiput, clinodactyly of the 5th digits, wide spacing between the first and second toes, and hypotonia. So now you have to figure out what that describes. He's cyanotic. His lung and abdominal exams are normal, and no heart murmur. Pulses are normal. So what's the likelihood that this infant will have clinically significant congenital heart disease incidence? So I guess they're telling you he's cyanotic, so I should redo this question, because if you're cyanotic, then it's probably 100%. So, but if he wasn't cyanotic, you're describing a child who's Down syndrome. Okay, so these are signs of Down syndrome, trisomy 21, and 50% of these patients have significant congenital heart disease. That's why we've gone currently to recommend screening echoes on all newborns, or all, neonates within the first couple months of life. They should probably get an echo. We'll see if those guidelines stick around. But yep, so most of you got the answer correct. C is the correct answer. And it's usually quoted about 50%. Okay, number 24, we're getting in the home stretch. A 21-day-old infant brought to the ER, 2-day history of poor feeding and lethargy. Okay. Pregnancy, labor, and delivery were uncomplicated. He went home at 48 hours of life. So he did fine after birth and went home at the normal time. On exam, his heart rate's 220, respiratory rate's 80, so both of those are fast, and blood pressure's lowish, 50/30. He's pale and mottled, cool extremities and weak pulses. Okay, so what's the most likely diagnosis here? Atrial flutter, ASD, SVT, supraventricular tachycardia, tetralogy flow, or double aortic arch. And so this one Dr. Aziz just talked about. So the answer is 3, or C, SVT. So the clues here, 21-day-old, so 3-week-old, so past usually the time of ductal dependent lesions. Those usually present in the first couple weeks of age. They'll probably give you that on the boards. They won't try to trick you with left-sided obstructive lesions, right? So those usually present by about 2 weeks of age. Another clue here is heart rate, 220. That's typical, 220 or above is typical SVT for infants. All these other, flutter would be unlikely to present at this age. That usually presents right at birth. ASDs don't present at this age. This is not tetralogy flow that presents with cyanosis. And double aortic arch presents with respiratory symptoms when kids are older, not in the first month of life. Okay, and so there's your answer key for all of you that want to take this home and look at them again. Does anybody have questions about any of the scenarios we went through? That's good. Okay, well, I hope you all pass the cardiology section 100%. Okay.